Okay, so now we're going to head on to the respiratory system. And for our first lecture, we're just going to talk about the anatomy to make sure that we're all on the same page with what's what and where it's located and the very basic functions. In the next two lectures, we'll talk more about the physiology. So lecture 27, respiratory anatomy. We're going to start with the nasal cavity and the sinuses. We'll start with the case of Noah and his nose. So Noah has a really bad cold and his nose is super stuffy. And because it's so stuffy, he has to breathe in and out through his mouth, and he finds that this is really uncomfortable. The air coming into his windpipe or trachea is really cold and dry, it's irritating, and he's getting a sore throat from having to breathe in and out of his mouth instead of through his nose. So already that's given us a clue as to what the nose actually does for us. So the nose, you think of it basically as only what you can see on the outside. But if you look on the inside, we have these structures called turbinates. And they're these bony protrusions inside the nose that are covered with mucosa. And what they do is they make the air that's coming in have to do all kinds of swirling around. It slows it down and swirls it around. So what's the point? Why do we not just want the air to get right in as soon as possible? Well, that extra time swirling around the nasal turbinates is going to help warm the air. So we have lots of capillaries in the mucosa or the epithelial lining inside the nose that acts kind of like a hot water heating system. So it's going to warm the air as it kind of circulates over and around those mucous membranes. It's also going to moisten the air, right? Because we have all kinds of mucus covering that mucosa. It's all slippery and gooey, and so that also helps to humidify the air. And then finally, the nose also is going to trap debris, both dust and germs, right? Potential bacteria and viruses. So we have hairs in the nose at the opening, right, at the nostrils or the nares to help filter and trap out large particles. And then the mucus itself is sticky. So stuff that's in the air tends to get stuck to the mucus, and then it can't travel with the air down deeper into the respiratory system. So when you breathe through your mouth, your air doesn't get warmed, humidified, and filtered before it comes into your trachea. So that's really uncomfortable. So a pro tip here, if you have a really stuffy nose, run a humidifier, right? Just humidify all of the air. And also if you can turn up the thermostat a little bit, keep the room a bit warmer, that'll also be more comfortable. Or pull the blankets up close to your face, not so close that you're suffocating yourself, but close enough to increase the warmth and humidity of the air that's close to your face. All right, now let's talk about the sinuses. So Simon is Noah's friend, and he has a really bad cold, and it just hasn't gone away. It's been over 2 weeks, and now it's getting worse. And he has a fever, and he has pain in his cheeks and kind of between and behind his eyes. So these are pretty classic symptoms for a sinusitis or a sinus infection. So what are the sinuses anyway? It's very bizarre. They are these caverns in our facial bones. So we have our maxillary sinuses here, one on each side in the maxilla, frontal sinuses up here in the frontal bones, and then back behind the eyes you have the ethmoid and sphenoid sinuses in the ethmoid and sphenoid bones, which hopefully you remember from back when we did the skeletal system. So these are little caverns or caves inside those facial bones that are lined with mucosa. And what happens is as you breathe, the air not only gets moved around those nasal turbinates, but it also enters into the sinuses and circulates around and then back out. So this further increases the surface area for the air to interact with the mucosa. So we get more warming, more moistening, and more filtering of the air. So these are two excellent video clips that I've posted in Canvas for you to take a look at. One is a review with some animation of the sinuses, and the other one shows you what we call the mucociliary clearance, which is how we kind of move mucus around and through our respiratory system to help constantly clear and clean it out. Let's talk about Ophelia. She has the same cold, and she's not as sick as they are, but she finds that she can't smell anything, and because she can't smell anything, her food actually doesn't taste very good. So this is because your olfactory cells, which are located in your olfactory bulb, which you might remember from the nervous system, right? So this is the base of the brain right here, the underside of your cerebrum, of the frontal lobe. And those two olfactory bulbs, they send little nerve fibers down into the nasal cavity. And here we can see the nasal turbinates, 1, 2, 3. Right? And so when you have a cold and there's inflammation and swelling of this mucosa, then sometimes those odor sensing or olfactory cells just can't function as well. What about Terry? He has something stuck in his eye, and so his eye is watering really badly. We've all been there. And then all of a sudden he notices his nose gets really runny too, and he's like, why does that happen? Why, when my eye is watering, do I all of a sudden get a runny nose? Same thing happens if you're crying for any reason. Well, it just so happens that we are constantly making tears through these lacrimal ducts, which are lacrimal glands, which are tear glands, and they're constantly clearing off and washing off the surface of our eyeball. It's happening all day long. What happens then, and the reason why you don't have tears dripping down your face, is that that liquid drains into these two little puncta, these two little tiny holes. If you take a break and you go look in the mirror and you pull down that lower eyelid, you'll be able to see this tiny little hole. This is one that's usually easier to see, but there's also one up here. And those tears then drain into a tube called the nasolacrimal duct, and it drains down into your nose. So this is your nostril right here. So it drains down into your nose. So anytime your eye is watering or you are crying, that liquid will come down into your nose. Now we're going to move on to the pharynx, which is a fancy name for the throat, and its accessory structures, because there's some cool things located in the pharynx. So first of all, pharynx is our fancy name for a throat, and we divide it into 3 sections. The nasopharynx, which is the part that's behind the nose. The oropharynx, which is the part behind the mouth, right there. And then the laryngopharynx, which is the part behind the larynx. Okay, so just remember the order. Nasopharynx, oropharynx, laryngopharynx are the 3 different regions of the pharynx. This is the tongue right here. It's a huge muscle. So what's going on in the nasopharynx? Well, poor Eustace here has a cold also, but it's not too bad. But her ears are really bugging her and driving her nuts. She feels like she can't hear normally. She feels like there's a pressure in them, like she needs to pop them, like when you go up in an airplane or if you dive down really deep in a swimming pool. It's just really uncomfortable. So this is a problem with the Eustachian tubes. So Eustachian tubes are these little tiny tubes, here it is here, that leads from the middle ear, which is the space behind your eardrum, and it opens down into the nasopharynx. So here you kind of have another view. Here's this tube, and it opens down into the nasopharynx. And its job is to drain any fluid that accumulates behind the eardrum, as well as equalize pressure across our eardrum. The way our eardrum works is kind of like the surface of a regular drum. If sound waves are present, it will vibrate. In order to be able to vibrate, however, it has to be loose enough. If it's really tight because it's sucked in or it's bulging outward and there's too much pressure, then it can't vibrate. So when your Eustachian tubes aren't functioning properly because they're swollen to the point where then they are blocked, which can easily happen when you have a cold, you can't equalize the pressure across the eardrum. So that eardrum can't lay nice and flat, it can't vibrate freely. And so like here, it's bulging inward, right? You can kind of see it. There's just, because she can't equalize the pressure, right? So that's why if you go up in an airplane, sometimes people are like, oh, try to yawn, because that'll stretch the opening of the Eustachian tube. Chew gum, right? Because that kind of swallowing, every time you swallow your spit when you're chewing gum, can help encourage the Eustachian tube to open. So a little pro tip, if you get this because of a cold, if you use a decongestant, right? So decongestants like Sudafed or Indayquil or NyQuil, or even the nasal spray ones like Afrin, that can decrease the swelling in the tube and help open it up and alleviate your discomfort. Be careful with the nasal decongestants. You never want to use them for more than 3 days at a time because your body can get kind of conditioned to it. All right, next up is the oropharynx. So nasopharynx has the openings to the Eustachian tubes, which is kind of cool. What does the oropharynx have? Well, it's got some tonsils. So here's Tonya. She has a really bad sore throat and she feels terrible. She comes to the student health center and we say, well, guess what? You have tonsillitis. Just like, what are tonsils anyway? So if we look inside the mouth, right, so we're looking back here in the oropharynx when somebody opens their mouth nice and wide, you can see the tonsils are one on each side, way far back in the throat. And they're this really strange spongy tissue, and it contains immune cells to help fight off bacteria and viruses. In some people, the tonsils are normally rather large, and in some people, they're so small as to almost be impossible to see. A couple of other structures here, anatomy-wise, that I want to point out to you, the uvula, which is that dingly down thing in the back of your throat. The soft palate, which is this whole region here that is very soft. And then the hard palate, which is that hard roof of your mouth. And that's hard because it is bone, right? You have the palatine process of the maxilla as well as the palatine bone itself. You might remember that from a long time ago. So tonsillitis is inflammation or infection of the tonsils. Can be due to bacteria such as strep, like when you get strep throat, or viruses such as mono, or even lots of regular cold viruses can do this too. It can cause throat pain, obviously, and fever. And if it's really severe, sometimes it can be so painful or the tonsils can be so enlarged that you can't swallow easily. And if that happens, you need to go get treated. Here's an example of somebody with some pretty bad tonsillitis, right? So look how huge this tonsil is, and you see this white stuff on it. That's pus from the infection. So they still have an opening into their oropharynx, but it's mighty small. So we're glad this person came to the doctor. All right, moving on down now. So we did nasopharynx, then nasopharynx with the opening of the Eustachian tubes, oropharynx with the tonsils. What's in the laryngopharynx? I'm so glad you asked. One of my favorite body parts. It's called the epiglottis. So the epiglottis is right here, and it's a rigid tab of cartilage. And its job is to decide what things are going to go down this way into the esophagus and what things are going to come this way into the trachea. Now, if everything's working properly, food and drink should go into the esophagus only, and air should go into the trachea only, right? So let's think about Eli, right? He's a social guy, always laughing and talking, and he finds he's always choking when he's like going out to eat with his friends. So he's like, oh, something must be wrong with my throat. And the nurse says, no, it's just because you are overworking your epiglottis. So it's like this. You can either send things here or here, one or the other, and this is going to be your crossing guard. This is going to be your security guard that tells you which way you're going to go. Here is a very close-up view of the inside of somebody's mouth. You might be like, Dr. Hall, this is the oropharynx. It is, but down here is the beginning of the laryngopharynx, and this is the epiglottis right there. It's this rigid tab of cartilage. It's not common in adults to be able to see it when they open their mouth really wide. In children, you can. Biologically, if you are in your late teens or early 20s, sometimes your body is still a little bit more pediatric than adults, so you might want to pause this and go to the mirror and see if you can see your epiglottis. You may or may not be able to. But again, it's like a traffic cop. It's saying who gets to go where. So poor Eli, right? So if you're going to be talking, you need air to come up out of your trachea and through your vocal cords. So your epiglottis has to have things be open here so the air can move in and out. But if you're trying to eat and swallow, then the epiglottis has to close so that none of the stuff that you're eating will get in. So the problem with Eli, right, is that you can't talk and eat at the same time, right? You can do one or the other. You can't do both because the epiglottis has to close if you're going to swallow some stuff, and it has to open if you're going to talk. You can't just have it halfway. Okay, so that was the upper respiratory tract, and now we're going to move into the lower respiratory tract. One of the things that we talk about in the lower respiratory tract is the conducting zone, which these are tubes that are just basically transporting air in and out of the respiratory system, right? They're just passageways. And then the respiratory zone where actual gas exchange occurs. So that's where we're actually moving oxygen and carbon dioxide in and out of different spaces. But for most of the respiratory tract is the conducting zone, right? Okay, so here we go. Let's start with the larynx. You might be like, aha, we talked about the laryngopharynx. Now we're going to talk about the larynx that's in front of it. So poor Larry has a cold too. Everybody has a cold these days. But what's bothering him about his cold is that he can't seem to talk. His voice is really hoarse. So we call this laryngitis. I think you've noticed we just put itis on the end of something if it's inflammation of that thing. So laryngitis is inflammation of the larynx. So the larynx is also called your voice box. So there's this rigid cartilage, right? So this is a frontal view. And then if we look down on it from the top, we'll see that you have your vocal cords stretch from one side to the other. You have two, one on each side. And so you have this, big band of cartilage, big ring of cartilage all around it. And your epiglottis right up here, making sure that food doesn't get down into your trachea. So your vocal cords are really quite amazing. They're these really thin membranes that are stretched across this opening. And we have muscles that allow us to make that opening between them wider so that we can take a big breath in, or to make it teeny, teeny narrow. And when we make it teeny narrow is when we can actually produce sound, right? So think of it about similar to how when you're going to whistle, if your lips are wide open, right, you don't really make any noise, but if you purse them really closed, I'm a terrible whistler, but you get the idea that then you can actually produce sound. So you have to bring the vocal cords close together in order to generate vibrations that produce sound. So this link, which is also up in Canvas, is some brave souls who are incredible singers who agreed to have their vocal cords filmed while they sang. So they took fiber optic cameras, went in through the nose, down the nasopharynx, oropharynx, and then laryngopharynx and into the larynx, and are filming their vocal cords while they are singing. It's amazing. So definitely watch that. So laryngitis is when your larynx gets inflamed and it gets swollen. So this would be normal over here on the left. And here's an inflamed larynx. Here's somebody who has laryngitis. It's all swollen and puffy. And so those vocal folds can't vibrate normally. So your voice is going to sound really strange. Now, of course, inflammation of the larynx can not only be caused by viruses like colds, but also by overuse, right? So if you've ever, been out to a party that's really loud and you've been yelling, and then the next day your voice is kind of shot, that's because it's all swollen like this. Same problem, different cause. So there's a little bit of controversy as to whether the larynx is technically the upper respiratory tract or the lower. I won't ask you, there's not a definitive answer, and really, I don't care. So just think of it as the transition zone. All right, so we're going to move down into the lower respiratory tract, still the conducting zone, and talk about the trachea. So Trisha, she was sanding some wood furniture the other day, and she didn't wear a mask because she donated it to her local hospital, and she doesn't have a sander with one of those handy-dandy vacuum attachments to catch all the dust. What is it called? Sawdust. There we go. To catch all the sawdust. And so now, like a day later, she finds she's keeps coughing, and it's this yucky brownish looking mucus. And she's like, oh, this is horrible. Do I have some type of lung infection? So the question is, what is happening here? So the trachea is this tube, right? So here's your larynx up here. Trachea is this tube through which air is going to move to get down to where your lungs are. When we look at the trachea, we see multiple cartilage rings. And those keep it, they're rigid. You can feel them. If you feel the front of your neck, you can feel those cartilage rings. Go ahead and do it. It's really interesting. And so there's a little space in between them, which is good, so you can have flexibility, so you can, turn your head and your neck all those different ways. But the tracheal cartilages are only a C-shaped ring. So they keep it open, but on the posterior surface back here, there's just a membrane. And the reason for that is sitting right behind is the esophagus. And what you can't see here, but right behind the esophagus is your spine. So there's not a lot of room there. So if you want to swallow a big mouthful of something, you need to be able to have your esophagus expand. So this needs to be able to push into this space a little bit when you swallow. So that's why the trachea has these C-shaped rings to keep it open and protected, but yet allow for you to still be able to swallow something more than liquids or pudding. All right. So poor Trisha, what was happening? So when we look on the inside of the trachea, we see our old friend from the beginning of the semester, pseudostratified ciliated columnar epithelium. Here they are. It looks like multiple layers, but it's really only one single layer. The nuclei are just at different heights. And we have these little hair-like projections or cilia on the tops of the cells, which you'll remember kind of like you put your arms over your head and it goes whoosh, whoosh, and the cilia beat in one direction. What you can't see in this image, but you know is there, are goblet cells, right, which produce mucus. So you produce mucus, which then ends up sitting, let's see, so you get like a nice layer of goopy mucus on the surface of these cells. And then your cilia and the mucus traps debris, right? And then the cilia beat and they move it, right? And this whole thing gets moved up out of your respiratory tract, up out of your trachea, into the back of your throat, and you cough it up and out. So when you have a lot of stuff, right? So she has a lot of sawdust that got trapped because she was breathing it in. And so it's taking her a while to get it all out. And so she's producing extra mucus because there's a lot of stuff that we have to clean out. Now, on a daily basis, this is happening on a smaller scale. So every single day, even though you're not aware of it, this is happening. Mucus on the surface of your pseudostratified ciliated columnar epithelium on the inner lining of your trachea. The mucus is trapping debris, and the cilia are moving it up the trachea into the back of your throat, where you unconsciously swallow it all day long. Yum, right? But this is how our lungs keep themselves clean. All right, this is another awesome video of what we call that mucociliary clearance, or mucociliary elevator is sometimes what it's called too, because it's the mucus and then the cilia that are moving it up and out. Okay, we're going to continue downward to the bronchi. So Britta has asthma, and when her asthma flares up, her breathing gets really difficult, her chest might feel tight, and she coughs and she makes this wheezing sound. So this is a link to some audio of what wheezing sounds like through a stethoscope, but you know, it's kind of like a I can't do it. I'm terrible at doing impressions. So you're going to have to click on the link. It's posted in Canvas and listen to what wheezing sounds like. So what causes that? Well, you already know that in order to generate sound, you have to narrow the diameter through which the air is going to pass. So let's look at bronchi and see what about them might end up getting narrowed. So first of all, here's our trachea with those C-shaped rings. Then it's going to divide into the, let me use a different color, into the right and left main bronchi, and each of those are going to branch into smaller secondary bronchi, which will then branch into further tertiary bronchi, right? So like the branches of the tree, we're taking air out to all the different parts of our lungs, right? The smallest ones, the itty-bittiest ones, are called bronchioles, kind of like how our tiniest arteries are called arterioles, same kind of thing, bronchioles. So bronchi also have cartilage rings to keep them from collapsing. They are also lined with a pseudostratified ciliated columnar epithelium, right? So they have that mucociliary clearance just like the trachea. But one thing that's different is that they have these bands of smooth muscle that surround them circumferentially. So that's what these are supposed to be, right? It looks like somebody's kind of taped it up, but those are bands of smooth muscle that you see. Now this allows the body to kind of customize where air goes. If these smooth muscles contract, right, they're kind of like a belt around the bronchus, they will squeeze it shut so not as much air can flow through there. So what happens in people with asthma is that the bronchi get inflamed and you get spasms of that smooth muscle, causing bronchoconstriction, right? Just like how arteries can constrict, bronchi can constrict as well. If this happens and the diameter narrows by about 20%, that'll cause a cough. If the diameter narrows all the way down to about by 80%, then that causes an audible wheeze. And you can also get shortness of breath because you can't move air as easily. So it's harder to get the air you need. So here we can see the smooth muscle is kind of cinching in and tightening up on that bronchus and making it very, very small, very narrow in diameter. We can also see in this example here how the wall of the bronchus that's pretty normal over here is now inflamed and swollen, which can also be part of the problem. So you might wonder how this is different from bronchitis, and the answer is not very much. Both are conditions where the smooth muscle spasms and narrows and constricts the bronchi and the bronchioles, and they can cause similar symptoms like cough and wheezing and shortness of breath. The only main difference is that bronchitis is due to an infection, usually due to a virus, occasionally due to a bacterial infection, but it's usually a virus. Whereas asthma, although it might be exacerbated or triggered by an infection like a cold, it's due to inflammation, and it can sometimes be triggered by other things like cold or exercise, or sometimes just bad luck, right? Nothing in particular. So now we're finally going to get to the respiratory zone where gas exchange is going to occur. So we've gone from, the nose and all through the nasopharynx, oropharynx, laryngopharynx, through the larynx, the trachea, the primary bronchi, secondary bronchi, tertiary bronchi, bronchioles, and now finally we're going to actually get to the business of the respiratory system. So Al has a terrible cough for over a week and it's getting worse, and now he's short of breath and has a high fever. He goes to student health and is diagnosed with pneumonia. he gets treated with antibiotics and begins to feel better. So what's pneumonia anyway? By definition, a pneumonia is an infection in the alveoli. So when we look at our lungs, we have two, one on each side, and they're this soft, moist, sponge-like tissue that's full of little tiny air pockets or air sacs called alveoli. So there's these little kind of grape-like clusters at the ends of each bronchiole. So I like this diagram because you can kind of see how you have bronchi branching smaller and smaller, and then you end in this little grape-like cluster of air sacs called alveoli. But keep in mind it's simplified, right? There's only like maybe 30 clusters of alveoli here, when in reality the entire lung is filled with all of these clusters of alveoli that are at the ends of bronchioles, right? They've just taken a lot of it out. Oops, that's not what I meant to do. They've taken a lot of it out just so that you can see what's happening. So the alveoli are the place where oxygen is going to move into our bloodstream and carbon dioxide is going to move out of our bloodstream and into the air so we can exhale it. We'll be talking about that in the next couple of lectures. So these are where the action is. So remember, for circulatory system, it was the capillaries, and for the respiratory system, it's the alveoli is where the important transfer is going to occur. So, oh, I forgot to animate that. So what we can see here is a cut open piece of normal lung. So this is a picture. It's supposed to show you a picture of full lungs. That's the right lung that I just drew an arrow for. All right, this is a magnified picture of a cut open surface of a lung. The color's weird because it's been dried out, but you can see these little teeny tiny little air pockets. These are the alveoli. When we look at this, when we take a slice of this, so that we can stain it and look at it under a microscope, it looks like this picture over here. So under the microscope, what we see are these are the air sacs right here, right? All at the end of bronchioles. But because of the way we make the slice, you don't see all of the walls depending on where you cut it. So our lungs are primarily filled with air, right? They're almost entirely composed of these little tiny air sacs called alveoli. This is kind of neat because you can see this is the cut surface. This is a bronchus, or an air tube, bringing air out, and then smaller bronchi branching off of it. All right, so on a chest x-ray, the lungs, here's your left lung, here's your right lung, basically. They look pretty black because they're mostly just filled with air. This here in the middle is your heart. And this here, you can see there's like these branching things. Those are the pulmonary blood vessels, right? So pulmonary veins and arteries. It's pretty cool to see that. All right, but when we look at most of the lung tissue, it's completely black because it's filled with air. What does it look like in somebody with pneumonia? Aha. So in this person, you can see for most of their lungs, right, on the left side, oh, it looks pretty good. It's pretty nice and black. But on the right side, ooh, there's like a big goomba here. This is a pneumonia. This is fluid and pus inside the alveoli. That is not normal. That should not be there. So pneumonia is when you have an infection in the alveoli themselves and they get filled with fluid and pus. So not only are you sick, right, and you feel unwell and you have a fever and you have a cough, but you can also get short of breath because you can't get air to exchange oxygen and carbon dioxide when the alveoli are swamped with fluid, right? You can't get air in there if they're full of fluid and pus. So thankfully for Al, his pneumonia was not huge. It only affected a part of his lung, and we were able to clear it up with antibiotics so that he got better. So you might wonder, what about COVID-19? So coronavirus infection, the novel coronavirus that's pandemic right now, can cause pneumonia, right? That's one of the ways, it's one of the primary ways in which it makes people super, super sick. It can also trigger this strange a counterproductive, overwhelming inflammatory response called ARDS, or acute respiratory distress syndrome. ARDS is something that can happen for a variety of reasons. A variety of medical problems can cause it, but COVID-19 is one of them. And what happens is that the capillaries get really leaky. And so fluid, right, plasma, leaks out of the bloodstream and into the alveoli, and immune cells as well. So in a pneumonia, you normally have some fluid and pus inside the alveoli. But in ARDS, you have this happening throughout almost the entire lungs. Basically, we call it kind of a complete whiteout. So this is an image of a patient with COVID-19. And they kind of started out with pneumonia. You can see all these white areas. This is fluid and pus in the lung, right? So they started out with what we would call a multifocal, meaning there's lots of different areas that are impacted by pneumonia. And then in the second image on the right here, you can see it's just a complete whiteout. So this person's alveoli on both sides, all throughout the lungs, except for we have like this little tiny bit up here, are just filled with fluid. So kind of just to give you a comparison, this would be a normal chest x-ray, right? Look at all the black, look at all the room for air that allows for gas exchange. And you can see on the right here that if you get ARDS, you basically drown in your own lungs, right? So your own lungs fill up with fluid. This is why people get put on ventilators, because by increasing pressure inside the lungs, you can help push some of that fluid back into the blood vessels. But it's also why the mortality rate is high, and why people end up needing to be on the ventilator for 2 to 3 weeks with this illness, and then even then sometimes not survive. Bad stuff. So in summary, we've talked about the nasal cavity and sinuses who work together to warm and humidify the air and trap debris. And then we talked about the olfactory cells because they're kind of fun, and the lacrimal duct that drains the tears from your eyes. The pharynx is divided into 3 regions: nasopharynx, oropharynx, and laryngopharynx, and each has some cool little features, right? So the Eustachian tube, the tonsils, and the epiglottis. We talked about your larynx, or your voice box, with those vocal folds or vocal cords. Those two terms are used interchangeably. The trachea that has those C-shaped cartilage rings, as well as our friend pseudostratified ciliated pseudostratified columnar ciliated epithelium with its mucus to get that mucociliary clearance to clear out not only the trachea, but also the bronchi. And then the bronchi have that additional feature of that layer of smooth muscle that surrounds them and can sometimes constrict, like in asthma or bronchitis. And then the alveoli, the little grape-like clusters of air sacs in the lungs, the ultimate destination of the air that we breathe in. This is where gas exchange is going to occur. So that's it for our first lecture on the respiratory system. I look forward to hearing your questions.